Thank you. So good morning, everybody. My name is Sara Dugan. I'm a psychiatric pharmacist and faculty at Neomed. I'm going to apologize preemptively. I have bronchitis, so I did take my cough medicine, but it may be interrupted a little bit. So I just want to apologize ahead of time. It seems to be linked to how much I talk. Our topic for today is trends in pharmacotherapy for opioid use disorders. There has been a handful of trials that have come out really looking at what do the prescribing trends look like. Much of it wanted to see pre, during, and somewhat post pandemic, or at least post shutdown time, what's happened with the use of pharmacotherapy for opioid use disorder, because it really impacted the way that a number of entities provided services for this patient population. So seeing that a bunch of that had come out in the literature recently, that was really where I wanted to do the focus. My objectives are twofold. So we're going to look at the list of pharmacotherapeutic agents, so which are the ones that I'm focusing on. I'm not going to focus on the supportive agents. I really just am looking at the ones that are being used for maintenance treatment of opioid use disorder. And then we're going to evaluate some of the literature to describe the trends that it is that we're seeing. To set that up, though, I wanted to take a little bit of a step back to think about why. Why does it matter where we're using these agents? Is it that important? Is there room to improve? Is this an opportunity? And you don't have to look far to look at why this may be an issue and something we should be paying attention to. The narrative is relatively clear related to the development and progression of the opioid epidemic. It's been well documented in a number of locations that there's been a continuous escalation in overdose deaths since 2000. It was interesting. I came across two different sources that really tried to provide a narrative. So looking at the backdrop of what was happening as we started to see this escalation. And there are a number of factors that played in. One of them being that pain was identified as the fifth vital sign that happened to coincide with the FDA approval of OxyContin and really the push to get pain under better control. That really led to a significant increase in the number of opiate prescriptions that were being prescribed and the amount of opiates that were then out and robustly available. Now, as we look at this graph on the lower left-hand side, so this is looking at overdose deaths that are followed over time. Those 4 different lines are for 4 different products, and I'm not sure how well you can see it. The dark blue line that ends up being up at the highest is for fentanyl. The very next line is for methamphetamine. That's really yellow. The third line is supposed to be an orangey color, and that's for cocaine. And then the light blue is for prescription opiates. As there were increased prescribing for opiates between 2000 and 2011, those prescribed agents really were one of the drivers that they saw for overdose deaths. So it was thought that just because they were out there much more robustly, not that it was always overdose of just that, often there were other substances involved, but they tended to be one of the drivers. Right around 2011, there was a pivot as individuals started prescribing less. And we saw folks who had previously been getting opiate prescriptions for pain management going other places, trying to get that substance from alternative sources. And there was a pretty significant spike at that time in the use of heroin. So heroin overtook the prescription opiates at that point and became one of the main drivers for the overdose deaths that we saw then. Right between 2013 and 2015, there was a pretty significant escalation in the availability of fentanyl. Up till that point, that really hadn't been something that was seen as much in terms of diversion or just robustly available outside of hospital systems, prescriptions, things like that. It was found to be easier and cheaper to manufacture than the heroin because of its increased potency. There was a definite significant shift in the illicit manufacturing of this product, which has just continued to escalate. And then we've seen pretty impressive modifications to that product to be able to try to come up with even more potent products, carfentanil being one of them. So that increase has gone up more than sixfold over the course of the last couple decades. The number of overdose deaths in 2021 was estimated to be about 80,000 that were due in part or primarily to opiate medications. Now, this translates to 9 per hour per day. And I just thought that was really telling. So and that was in 2021, but within that time frame, within the time frame that we're together this morning, that would be 9 individuals that would pass away as a result of overdose from the opiate prescriptions. That's a number we can definitely do something about. Obviously, previously those numbers had been significantly lower. So that's where I'm going to challenge that our opportunity is. And I know I'm preaching to the choir, but I thought it was pretty powerful to look at that over time. The other chart that's down here on the lower right-hand side is the death rate per 100,000 people. And this was due to all opiates. And they looked at from 2011, it was about 7.3. And that was really seen as a higher point because it had been about 3.2 or 3.4 before that, going into the 2000s. In 2021, it had jumped up to 24.7. So we really saw this rapid escalation. And with this attention and the fact that that's been going on for a longer period of time, as we look at our prescribing trends, they don't appear to be keeping pace with what this data is suggesting. So, okay, those were overdose deaths. Not everyone who has opioid use disorder, thankfully, passes away due to overdose. So how much is the use a problem? So this is data from the National Survey on Drug Use and Health. So this was the most recent one that I could get my hands on. So it had data from 2022. The people who responded to this that were 12 years and older, the number who misused opioids in the last year was 8.9 million. So yes, it was only 3.2%, but 8.9 million. And of those individuals who were misusing opioids, 8.5 million were still misusing prescription pain medications. Not that that's the best information that we're looking for, but in terms of that overdose data, that would suggest that that really isn't the driver of the issues that we're seeing. 1 million had reported that they were using heroin, and 587,000 were misusing opiates and heroin together. Moving to the right-hand side, those who were 12 years and older that reported misusing fentanyl, so they actually asked for that separately in this just because they'd identified that it was really a significant concern. It was under 1 million, so 991,000. The number that were using illicit fentanyl was 686,000, and this was a significant increase. So we do see pretty consistent use of fentanyl, but where they're getting that medication from actually is shifting a little bit, with the illicit fentanyl taking a much bigger footprint, which I do think is concerning. The asterisk is there to remind me that this is likely a underestimation. It was identified that the illicitly manufactured fentanyl, they called it IMF, the illicitly manufactured fentanyl was present in a number of other products. So it was found in cocaine, it was found in meth, it was found in marijuana. So this was just asking if they were using that intentionally, and it really didn't capture the amount of individuals who are being exposed to that in other means. So maybe a little bit less intentionally. Now, just because they misuse doesn't necessarily mean that they have opioid use disorder. So in looking at the number of folks who met criteria for OUD in 2022, It was about 1% for individuals who were between 12 and 25 years old. And then those who were 26 and older, it was about 2.5%. Now, in just a little bit, we'll look at some trends in prescribing that does break it down by age. And I just would like you to remember this. So even though the 12 to 25-year-olds, it was about 1%, we may be underestimating this patient population a little bit. So that's my teaser for later. So there's an issue. This is still a significant problem, and we do have a handful of medications that are available to assist with treatment. Now, it hasn't diversified. Again, I just focused on those that were approved for maintenance. I'm going to combine buprenorphine alone and buprenorphine naloxone, just because most of the studies that looked at trends did do that. But we're going to look at trends for each of these products. I included this just a little bit as a reminder. So we have a handful of different options that may assist with folks who are in different situations. While our formulations have diversified, and that's helpful, it really hasn't diversified off of what we're targeting at this time. And I know there's significant interest on the research side to try to find other treatments that either can be used adjunctively or collaboratively with these products, or other targets that we need to go after to make a bigger dent in the efficacy of treatment of OUD patients. So for treatment, how are we doing in general? Just as a reminder from the National Survey on Drug Use and Health, there was 8.9 million individuals who reported that they were misusing the opioids. For those that received treatment for any substance use disorder, so the data, excuse me, the data did not pull apart treatment for specific substance use disorders. They just gave substance use disorder in general. So this included any type of stimulants, alcohol use disorder, it included marijuana use disorder, and it was just over 6 million. So there were 8.9 million who were misusing our opiates, but yet we only have 6 million individuals who are in treatment. So that really suggests that we have a pretty significant discrepancy. That would be concerning if it was just opioid use disorder. They did provide some estimates for the number of patients who had received inpatient and outpatient treatment for opioid use disorder. Outpatient treatment was just over 2 million, and inpatient treatment was 712,000. So even with that, we're under 3 million. So we're not even at the halfway point for individuals who have been engaged in treatment. So I'm going to say that that's at least an opportunity for us to improve some of those numbers. So for each of the medications, what's been changing over time? Are we making a dent? Are we moving in the right direction? So for the buprenorphine products, the first study that I found was one of the reasons I wanted to do this particular talk, because I had come across it. So it was something called a time series analysis. So they wanted to compare prescribing rates from January of 2019 to April of 2021. So as they were collecting the data, the reason they picked April of 2021 was when they had access to a comprehensive data set. Now, the information that they used was the National Prescription Audit, the Payer Track, and then the Total Patient Tracker. So they actually used these databases that included claims data from most of the retail pharmacy dispensing. So when you write a prescription, not all of those prescriptions get filled. There is some degree of prescription abandonment. So this was really looking at the dispensing. So the number of pharmacies that actually processed the medication to request payment. There is a large fraud, waste, and abuse infrastructure in place. So if a pharmacy fills a prescription, they need documentation that got picked up. They can't just fill the prescriptions and let them sit somewhere and put them back if folks don't come get them. So that really is a fairly accurate representation of at least the patient getting the medication. It included more than 92% of the buprenorphine products that were dispensed. There was a little bit of issue with some of the billing and some of the data access, but they were looking at, so what were those rates of buprenorphine being prescribed? So the results that they found, so the number of patients in the thousands is here on the y-axis, and then the dates are along the x-axis. The little circles are the observable points. So as they were looking month to month, they had averages. And in general, it started out relatively lower. We saw an increase going into the pandemic. And then the line is just the average trend. So they use a statistical manipulation to see generally, because those bubbles are up and down. Is it going up? Is it going down? What did the averages look like? And generally, the prescribing was going up. Once COVID hit, they did see a shift. So the dotted line is what they would expect if there had been no change. And there was a pretty significant deviation where the number of prescriptions and the rate of prescribing buprenorphine did fall off slightly as a result of the pandemic. I think the good news is it didn't have a complete downward slope. Excuse me, it looked like it stabilized. But we did lose a little bit of ground during that time. Now, there were a lot of other factors. So there were individuals who may have difficulty getting to a lab, getting to a clinic. Not everybody was completely up and running at the same time. There may have been some housing or other factors that were going on. So yes, we saw a bit of a change, but the hope is that that trend would continue to go up. Now, who is prescribing? So recognizing that maybe we had a bit of a setback, we want to look at who it is that's prescribing, and is there an opportunity for us to make a difference there? So this was an analysis that was done using the National Ambulatory Care Survey data. So this is a national database. Healthcare providers from all across the nation are asked to fill this out over a short period of time. So they fill out a number of different information on this survey. It can look at prescribing habits. It looks like healthcare access for some of the patients, who's getting care where. It's not just primary care. It's anyone who's getting outpatient appointments. What they found, so they included the data they analyzed the data from 2006 to 2014. Now, these are the number of visits on the y-axis. Dates are across the x-axis. Blue bar is psychiatry. Red bar is primary care. Primary care was primary care, family practice, internal medicine, and general practices. And then were other specialties that were not psychiatry. So that really was a relatively large capture. What they saw over time was the individuals who were seeing patients for opioid use disorder did increase for psychiatry, but it tended to level out. We saw a huge jump between 2009 to 2011 data in 2012 to 2014 in primary care. They definitely got on board with assisting in treating a number of these patients. And then that other category also had a pretty significant jump. While they didn't specifically designate, there were a number of places that were identified that had diversified some of their offerings. Women's health, so OBGYN type clinics, some of the infectious disease type clinics. So there were a number of other places that really did kind of pick up that burden and move it forward, recognizing there was an unmet need. So we were seeing that was starting to diversify. So did that continue? That only took you to 2014. This was a study that was published in the JAMA Health Forum just this last year. And it was a cross-sectional study that looked at data from the Total Patient Tracker database. So again, those retail prescription data. So it captured the total monthly number of prescriptions. It could look at other things other than buprenorphine, but that was the main thing that they were looking at. But they also had data on prescriber specialty. So they pulled it apart to try to see if there were other individuals who were prescribing buprenorphine. Their data analysis went from January of 2003 to December of 2021. We see that overall, the prescriptions for buprenorphine were continuing to increase in a relatively linear fashion. But those non-psychiatry prescribers really were the ones that were driving that change. Psychiatry had kind of gone up, leveled off right around 2013, 2015, and it has remained a little bit consistent with a slight trend down. So it seems like even though overall access and treatment is increasing, it's outside of the psychiatry realm, which does include substance use disorder providers. So that was interesting because that is consistent with what the other study saw as well. So I think in general for buprenorphine, there are lots more individuals who are getting comfortable, changes with the data waiver. They have expanded the number of patients compared to when some of these individuals started prescribing buprenorphine. So there's definitely an opportunity for growth. And while we may not be getting everyone that we want on treatment, it is helpful to know that this could be collaborative. So there are other disciplines that may really assist with managing some of these patients. How about methadone? So it looks positive for buprenorphine. Methadone had way less data. I was a little bit surprised. I hadn't come across methadone data. I had seen the buprenorphine stuff, but I didn't think that I'd have trouble finding stuff for methadone. It was a little trickier. So Canada really has done the bulk of the analysis for methadone. I'm going to use the most recent information I could find. So this was from the JAMA Network Open publication. And they did a number of different cross-sectional studies. This was the one that was most relevant. So they looked at the data that was available from the province of Ontario. And they looked at from 2013 to 2021. And they wanted to compare the rates of opioid agonist treatment. So to be fair, this is not methadone alone, but it was methadone, it was buprenorphine products, and they actually also have slow-release morphine that's available as opioid agonist treatment. They didn't diversify, like they didn't stratify how much of each of them, but just in general. They did break the cohort into two different age groups, so 15 to 24 and 25 to 44. Now, what they found here on the left-hand side are two graphs. So the rate of opioid agonist treatment is on the y-axis, dates are across the x, but that blue line is overdose deaths. So on the right-hand side of what looks like the y-axis is the rate of overdose deaths per 100,000 in their population. So in the younger cohort, they see a significant increase in the number of overdose deaths due to opiates in the province of Ontario. Unfortunately, at the meantime, they saw a decrease in the prescribing rates of the opioid agonist therapy. So it looked, as I mentioned before, even though the prevalence looked lower in that younger age population, it's possible that's not the one that we've been targeting, and they may be more impacted by those overdose rates. For the patients who are in the 25 to 44, I just had a birthday on Wednesday. I am no longer in that age bracket as of Wednesday, so I wasn't going to say the older age bracket because that doesn't feel old anymore. They also saw an increase in the overdose deaths, but they did not see the drop-off in the agonist therapy. So they were still preserving it, and it looked relatively consistent. Slight dip during the pandemic, which, as we saw with the buprenorphine, probably was to be expected. But overall, it looks like the focus has been a bit more on that patient population. So methadone may be more consistent for our older patients, but maybe we need to be considering, is this a possibility? I recognize from a logistic perspective that might be tough for this adolescent, early adult population in terms of scheduling, but maybe there are some unique or creative ways we could look at expanding access to methadone as a treatment option for that patient population. All right, last one is naltrexone. Naltrexone was even more challenging. I put these in alphabetical order. They also happen to fall in order of the amount of literature that was available. So that was also helpful. There were two things I looked at with naltrexone. So interestingly, they had information related to pregnant patients. So that wasn't one that was specifically called out recently for the other two. This was a survey done for providers of opioid use disorder who specifically prescribed naltrexone. And they were looking at how often do they use this in patients who are pregnant. It was sent to 236 sites. The response rate was about 31%, which wasn't terrible. That actually wasn't too bad. There were more than 5,000 prescribers at those 236 sites that they were trying to get information from. What they found was just over a third offer naltrexone to their pregnant patients. So only 78 sites responded. And of the 78 sites that responded, only 23 said that they do offer naltrexone to their pregnant patients. Now, what they identified as barriers, which was helpful that the survey asked for that, what the leading reason was that most of those places did not treat patients who were pregnant. So if they had opioid use disorder and they were pregnant, they actually deferred treatment. The other causes were lack of national guidelines for use of naltrexone in pregnancy. And then the final two were discomfort. Both discomfort in not really having a clear idea of what the safety concerns were about naltrexone use in pregnant patients, and inexperience. Excuse me, they just did not feel comfortable prescribing it to that patient population. So it appears like potentially there is an opportunity to look at especially the data of what they've used. What have those outcomes been in those pregnant patients if they're saying that there's not enough literature? We used to have someone from an OBGYN clinic, Lulu Zhao, that would come in that actually made me think of her because it does look like there's an opportunity to contribute to the overall knowledge base there. The other study that I found was a cross-sectional analysis that was conducted by the VA. So the Veterans Health Administration looked at their database nationwide. They set up specific criteria. So they had to have an established substance use disorder program. They needed to have individuals who were prescribing extended release naltrexone injections for at least 5 patients on a chronic basis. So they wanted clinics and sites that had figured out how to use naltrexone and were doing this a little bit more robustly. So instead of all of the nationwide sites, they looked at only 16 of those 155 sites met that criteria. So they pulled data between 2011 and 2012 and wanted to see what were the prescribing rates. So at the sites that were using naltrexone a little more consistently, the prevalence rate of use of naltrexone injection was only about 1%. When they looked at the nationwide database of how often they're using naltrexone, it was only 0.26%. So it was less than half a percentage. Just from a numbers perspective, because those seem very small, even though the range got shrunk on there so that the bars look bigger, it was 179 patients out of over 16,000 that were getting the naltrexone injection at those at the 16 sites. Nationwide, so 179 at the sites that were routinely using naltrexone. When they looked nationwide at all of the sites, that number only went up to 256. So there were 256 patients total during that time frame that were getting naltrexone injection. And there was almost 100,000 patients who had opioid use disorder in the VA system. So that really does appear to identify this as either an option that we're not utilizing, or is it not a good fit for most of the patients? When they looked at who it was being used in, The main driver, or one of the main factors, was homelessness. So they used it more frequently in patients who were homeless. They were also more likely to be white. They were also more likely to have alcohol use disorder in a mental health diagnosis. So it appeared to be in a patient population where they didn't want to use one of the opioid agonists, but it was still a relatively small population. So it looks like we've got lots of opportunity. So in summary, opioid use disorder is still a significant public health concern. Less than half of patients who have this are actually receiving any type of treatment. And based on the trends, we do see improvement. So we are moving in the right direction, but we've still got areas that we could make improvement in. So with that, I will stop my share. I see that the chat has blown up. I apologize, I didn't get a chance to look at it. So
Oh, yes, there's been a robust chat discussion on overdoses, overdose trends, drug dealer motivations, any number of things that we could get to. But for right now, does anybody have any questions for Sara, or does anybody want to take a jump to bring what they shared in the chat to the full, for open discussion here?